Good afternoon, everyone. Welcome to Yetena Weg Research and QI webinar session. We'll be starting first by talking a bit about Yetena Weg, what our volunteer network digital health platform does, and a bit of an introduction on all of our activities. And then we'll be proceeding directly to our webinar. So Yetena Weg is an NGO registered in Pennsylvania, USA. It's a nonprofit organization run entirely by volunteer members. It has volunteers from across different countries. The major projects and engagements done at Yetena Weg consists of health promotion, which generally had discussion sessions and articles on general public health policy and implementation topics. And the other project or engagement we have is community engagement program, which organizes blood drives, inclusiveness and equity projects and fundraising campaigns. And the other one is mentorship and skill sharing program. This is entirely made as a program of direct mentorship, soft skill, career, and professional development webinars, and one-to-one mentorship programs organized for healthcare professionals. The other is medical education programs. This is basically what we are having now, which is a CME session, and the other one is research and QI projects. Yetena Weg is more than a digital platform. As you guys can see, it's reaching to the society and working closely with the society. So Yetena Weg, it's been a year since we started the Yetena Weg ROHA Research Fellowship Program in collaboration with Black Lion and St. Paul's Hospital. It was started on March 14 with Addis Ababa University on 3 departments: oncology, radiology, and internal medicine. And 3 grants were provided for 3 winners, and mentorship opportunity was provided for 10 winners. And Yetena Weg also worked with St. Paul's Hospital in organizing a fellowship competition for medical students or interns, and awarded grants for 4 winners. These are the winners from Black Lion Hospital, and these were the winners from SPHMMC cohort. So as we talked before, Yetena Weg partners with the Ethiopian Medical Association and Ethiopian Society of Cardiac Professionals and Ethiopian Society of Internal Medicine to provide continued training for health professionals. So we've had more than 30 CME webinars so far, and average webinar attendees is around 150 and 200 health professionals. So you can access our previous CME sessions on YouTube channels, including the Research and QYC webinar sessions. So to get more updates about our upcoming CME sessions and research webinars, you can join our Yetena Weg Telegram session for healthcare professionals, and follow our social media accounts on Twitter, Facebook, LinkedIn, and Instagram. For best experience on the webinar, you guys can send questions on the Q&A platform in the chat box. At the end of the webinar, you will have a chance to ask the speaker directly if you raise your hand. To get your certificates, you have to fulfill all these 3 criteria. First, you need to attend the whole session virtually. Minutes attended would be checked by Zoom attendee report. And the second is you need to fill the Google form for personal details and attendance. The third one is to get a 50% and above on the post webinar quiz. And you will get your results right away, but the certificates will take 1 to 2 weeks to be delivered to your email. So next, we'll be proceeding to introducing our panelists, or Dr. Wubet Mihretu. She's a healthcare quality specialist. She's a physician with demonstrated commitment on healthcare quality improvement, holding both a Masters of Public Health from St. Paul's Millennium Medical College and Masters of Science in Healthcare Quality obtained from Yekati 12 Hospital. She further strengthened her expertise by completing a fellowship in quality and safety from ISQA. For the past 5 years, she has served as a director of clinical governance and quality at Gandhi Memorial Hospital, where she has demonstrably led quality improvement initiatives within the hospital. So please welcome Dr. Wubet. Dr. Wubet, you have the stage.
Thank you very much, Sumaya, for our introduction. So my name is Wubet Mihretu. Today we will see about an overview on quality improvement. So to begin with, these are the session outlines. We will have an introduction and a science of improvement, and we will see problem identification, prioritization, and aim setting. And finally, we will see the concept of generating change ideas. As you all know, quality improvement is a broad concept, so we can't go through with a one session. So we will have upcoming webinar on measurement and testing. Today, our outlines are the following. So, as an introduction, what makes healthcare quality an agenda globally? There were two findings, there were two literatures. The first one is To Iris Human, Building a Safer Healthcare System, published in 1999 by IOM, Institute of Medicine, which the finding breaks the silence that has surrounded medical errors and its consequences. This book affords a national agenda in US, and patient safety is a big issue. The second literature was published in 2001. It also published by IOM, which is called Crossing the Quality Chasm. This literature highlighted the gap between the ideal quality of healthcare and the reality of what patients often receive. So what we call it the no-do gap, where what we are knowing and what we are doing are very different, and there is a big gap between them. So this finding makes an urgent call for fundamental changes to close these equality gaps. After that, different initiative was initiated by WHO and different countries. So the next thing we have to see is the definition of quality in healthcare. The first definition was by IOM. It says quality of care is a degree of health service for individuals and populations, increase the likelihood of desired health outcomes, and consistent with the current professional knowledge, which means this definition puts individuals and population at the center of care, and it encouraged to use the current evidence-based practice. The other definition we will see is Ethiopian NQSS definition, Ethiopian National Quality and Safety Strategy. We have National Quality and Safety Strategy as a country, which starts in place starting from 2030 up to 2070. The definition states that quality is a comprehensive and integrated care, measurably safe, effective, people-centered, uniformly delivered in a timely way, affordable to the Ethiopian population, appropriately utilizes resources and services efficiently. This definition looks a lot comprehensive and put all the quality domains in one sentence. So what are the quality dimensions? There are 7 quality dimensions according to the WHO. The first one is safety. When we say safety, safety is absence of preventable harm. By according to the patient safety report to 2024, improving patient safety can prevent half of the harm in healthcare facility, because it saves 3 million lives annually worldwide. The other domain is effective, being effective. When we say effective, it means care is given as per a current knowledge and recommendation. Our care should be evidence-based according to the current literatures, the current evidences. The other quality dimension is efficiency, which means a reduction of waste. It might be resource, time, and the likes. The other dimension is equity. As we all know, equity is fairness, and when we say equity, it is a care is delivered uniformly without any discrimination based on a political ideology, geography, gender, disability, ethnicity, or language. The other dimensions are timely. When we say timely, it is reducing unnecessary waits and sometimes harmful delays for both patients and for caregivers or providers. And the sixth quality dimension is people-centeredness. Previously, we called this dimension patient-centered, but currently we are much more approaching as a people-centered community approach, and we engage family and patients in our care. That is the current recommendation. So this dimension is called people-centered. So when we say people-centered, it means care that respects and responds to individual and family and community preferences, needs, and values. The last, or the seventh, the new domain that integrated in the quality domain is integration. When we say integration, it is a comprehensive approach that is provided in a combined way across the continuum of care. So we have to see patients as a whole, and we have to approach comprehensively. We have to address all the needs of our patients, including mental and social aspects. After addressing the domains of quality, there are principles of quality improvement. When we do quality improvement, the first principle is we have to know why we need to improve. Based on our problem, we have to set an aim. So we have to answer why we need to improve. The second one is we have to have a way to get feedback. When we say a way to get feedback, we have to measure our problem, and we have to know that intervention was worked or not. The third principle is developing a change. We have to develop effective change that leads us to an improvement. The fourth principle is testing. In quality improvement, we can't implement a change idea once. We have to test and we have to get a feedback. That change idea is a good change idea. So the fourth is testing. We have to test. The fifth principle is after testing, we have to implement that change in a full scale. So these are the 5 principles of quality improvement. So there is a science of improvement in a quality improvement. What is science? Science is a knowledge attained through a study or practice. And when we say improvement, it is increase in a value of excellence or of a quality of or condition. So there is a science of improvement. Improving is a science. Improvement is a science. So when we say science of improvement, there are 2 concepts that are change and improvement. From these pictures, we see 2 pictures. The first one is changing a bulb, and the second one is a weight loss journey. So we can clearly see that the first one is it's a change. It doesn't affect different parts of the system. While when we see the second picture, it is a weight loss journey. When we plan to lose a weight, we affect different parts of our system. We work on our calorie intake and our exercise. So there is improvement and there is a change. So if when we say science of improvement is when we say science is a knowledge, there are two types of knowledge. The first one is subject matter knowledge. Subject matter knowledge. When we say subject matter knowledge might be gained either formally or informally, but it is a professional knowledge, like being a pharmacist, being a nurse, being a medical doctor, or a lawyer. This is a subject matter knowledge gained through formal way. When a mechanic who gets that knowledge through experience is also, it is a subject matter knowledge. The other knowledge is a profound knowledge. This profound knowledge is the interplay of theories, of system, variation, knowledge, and psychology. This is understanding the system when we say profound knowledge. So to come up with a good quality improvement ideas, we should have these two types of knowledge. Both subject matter knowledge and profound knowledge are needed in a creative way to develop effective change ideas for improvement. So Deming describes four components of system of profound knowledge. These are called lenses of profound knowledge. The first one is appreciation of a system, appreciation of the system. The second one is theory of knowledge. The third one is understanding variation. And the fourth one is psychology or human behavior. So these components are a profound knowledge components. We will see each briefly. The first one is appreciation of the system. Edward Deming says, if you can't describe what you are doing as a process, you don't know what you are doing. So there is a process, there is a system. So what is a process? A process is a sequence of steps or actions through which inputs from suppliers are converted into outputs for customers. And when we say system, this is the sum of all parts, including the processes that interact together to produce a common goal. So in healthcare, there is a system. What do you think form the healthcare system? What do you think is form the healthcare system? So the healthcare system are formed according to WHO. There are 6 building blocks of a healthcare system. The first one is leadership and governance. Leadership and governance. The second one is information. Information that we get day to day while we are delivering care. That information comes from the data, and we decide based on that data. The other building blocks of healthcare system is finance. Healthcare financing plays a crucial role. The other is the service we deliver, service delivery, and human resource. When we say human resource, the healthcare workforce, professionals or supportive staffs are included in this matter. The 6 building blocks is medicine, vaccines, and technologies. At the center, we do have people, because all are governed and executed by human beings. So at the center, we do have a people. So after seeing what constitutes a healthcare system, what is system thinking? System thinking is a big part in quality improvement concepts. So system thinking is a problem-solving approach that focuses on the interconnectedness of things rather than isolating individual parts. There is a famous saying or a famous quote in healthcare quality improvement, or when we think about system thinking, every system is perfectly designed to get the result it gets. In our OPDs, we see a lot of coups. That is not a fault of individuals or a fault of one part. It is the system's performance, its designs, and its operation. It's not simply a result of individuals' effort within the system. So every system is perfectly designed to get the result it gets, implies system performance is the result of its design and its operation. The second component of profound knowledge is understanding variation. In our healthcare system, variation is inherent and variation is unavoidable. Variation exists, and there are two types of variation. These variations are called common cause variation and special cause variation. So we have to understand that variation, where they come. If we see variation, we have to differentiate that variation is a common cause or a special cause. When we say common cause variation, it is inherent into the process or the system. When we say special cause variation, it is not inherent in the process or system. Something caused it. Something caused it. If we remove that assignable cause, the system becomes, the variation becomes common cause variations. So in common cause variation, we say our system is stable. But if we found special cause variation, our system is unstable. It doesn't mean special cause variation has both common cause and special cause variation. In healthcare system, there is a tool which help us to understand or to differentiate variations. This is called system performance control or control chart. By plotting our data over time in control chart, we can differentiate whether it is a common cause variation or a special cause variation, and we come up with improvement idea according to the variations, based on the variations. If the problem is inherent and caused by a common cause variation, we need system redesigning. And this problem only addressed by making fundamental changes. So the third one is theory of knowledge. Theory of knowledge is the third part of profound knowledge. Knowledge talks about the needs to learn from the hypothesis or prediction. So this prediction needs to be tested to learn how it is influencing or impacting the system we are trying to improve. There is a tool, we build a knowledge and we learn from that knowledge, which is called model for improvement. In a model for improvement, there is one component called a PDSA. PDSA means planning. We plan our intervention, then we do that intervention, and we study that intervention. What makes that intervention to our outcome? So while studying our intervention and its impact in our outcome, we developing a knowledge, we developing a hypothesis. So this is theory of knowledge is the other part of profound knowledge. The other is psychology of change, or human side psychology. As we all know, dealing with human beings it's a little bit tricky. It needs a special skill. So we have to understand human psychology towards change. So this helps us to predict how people will react to change, understand behaviors that drives people's motivation, either intrinsic or extrinsic motivations. The other thing, we tend to avoid blaming people for poor outcomes rather than review the process, design, and its operations. So when we have a system thinking, we avoid blaming people, and we do a root cause analysis in our system, because our system is responsible for the outcome, not only individuals. So blaming people for the wrong outcome is called fundamental attribution error, just what we call it in Amharic በአንድ ሰው ላይ መደፍደፍ or ማላከክ. So our environment, our healthcare system should be free of fundamental attribution error. So the opposite of fundamental attribution error is just culture. Our healthcare system should have a just culture and need to have analyzing root causes when something goes wrong. So after saying this, briefly discussing about profound knowledge, uh, while we doing quality improvement projects, we use models, quality improvement models. There are different types of models. These models are pseudo innovations. Pseudo innovations means the same concept with different naming and different nomenclature and different processes. The common quality improvement models are Kaizen and model for improvement. But Six Sigma, Lean, SBMR, Challenge are there. And there is also hybrid models, Six Sigma and Lean. These quality improvement models came from the manufacturing companies to decrease their defects and to increase their effectiveness. And we adopt from that, and we used these quality improvement models to do QA projects or quality improvements. In Ethiopia, we use, or the Ministry of Health approved two quality improvement models. The first one is Kaizen. From the Kaizen, we use only 5S as an entry point to clean and to organize our workspace. So Kaizen 5S is as an entry point we use in quality improvement models. The second one is model for improvement. Model for improvement has two components. The three fundamental questions and PDSA cycle. Two components, which are three fundamental questions and PDSA. The three fundamental questions are: what are we trying to accomplish? The first one. This means setting an aim based on our problem. The second one is: how will we know that a change is an improvement? This is developing a change idea. The third one is what change can we make that will result in an improvement? This is measurement, measuring our outcome. And a PDSA, this is testing. So we will see briefly how we do model for improvement. So first, to do a quality improvement, we have to identify our problem. We have to identify problem. So we used most of our time in identifying our problems, because ያው በእኛ ሀገርም ምን ይባላል ችግሩን ካወቅ ነው 50% የመፍትሄ አካል ነው የሚባል የተለመደ አባባል አለ። Einstein ደግሞ ምን ይላል? What Einstein said, if I had an hour to solve a problem, I would spend 55 minutes thinking about the problem and 5 minutes thinking about the solution. If we know what is the problem, it is simpler to come up with a change idea or a solution. So in a healthcare system, where we found our gaps is the question. The first one is a day-to-day registration, our registrations, HMIs, and our data from DHIS, national DHIS reports. The other is doing audits, be it a clinical audit like mortality, morbidity, treatment audits, or system audit. The other is patient complaints, or by doing survey like patient satisfaction survey. So after finding a problem, that means we get an opportunity for improvement. We identify an opportunity for improvement. So we have different and many problems in our healthcare system. So we can't do quality improvement projects in all at once. So what we do? We prioritize our problems. When we prioritize our problems, there are prioritization tools we used. The first one is called Pareto chart or Pareto principle, or it says 80-20 rule. 80-20 rule. This roughly states that 80% of the effects come from 20% of the causes. We use this rule when our outcome or our effect is the same, like mortality, patients more than 24 hours at emergency, the like. When we see mortality in neonatal, in newborns, there are different causes. Asphyxia, prematurity, sepsis. The causes are different, but their outcome is the same, days, neonatal days. So we identify the major that contribute 80% and we act on them. So this Pareto chart needs a frequency, cumulative frequency, and the causes. And we can simply do Pareto chart in our Excel. There are different tutorials in YouTube you can find there. For example, when you see types of medication error, there are 430 medication errors caused by different causes, like dose missed, wrong time, wrong drug, overdose, wrong patient, wrong routes, wrong calculation, duplicating drugs, underdose, wrong IV rate, technical error, and unauthorized drug. These are the causes of medication error. So we identify which contributed more and act on them. So the 80% called vital few, and the rest, or the 20%, called trivial many or useful many. So this is the first prioritization tool when our outcome is the same. The second prioritization tool we used to prioritize our problem is priority matrix. We use priority matrix when we gather different problems that cause different outcomes, like mortality, medication error, patient long waiting time, length of stay, and the like. And we set a criteria. These criteria are based on the cost, the availability of the resources, the urgency of solving, and size of the problem. So based on the frequency, the importance, the feasibility, we set as a team, and we rank. It has a little bit subjectivity, but we decrease that subjectivity by doing it in a team and by taking average rankings. So we do quality improvement projects with a higher rank, problem with a higher rank. After prioritizing our problem, what is the next step is writing a problem statement. While documenting a problem statement, there are do's and don'ts. Our problem statement should have a size. Without putting a magnitude, a number, we can't do quality improvement. There is no many, too much, and the like words in quality improvement. Quality improvement puts a fact with a size and a number. So we have to put a size, and our problem statement also should have a time. How long has it has been a problem? So when we study our problem, or when we gather data for our problem, it should be, our baseline data should be from 6 months up to two years. If the problem exists only for a month and the like, it might be by chance. It might not be inherent in our system. So we might not be doing a quality improvement project. So time is a very important aspect. The other is impact. What happened because of this problem? Are our patients dissatisfied? does this problem cause mortality, morbidity, and the like should be stated in our problem statement. And the last part is where we have to specify where the problem exists. What we don't need to put in our problem statements are causes. If the cause is obvious, why we need to do quality improvement projects? So causes are not stated in our problem statement, should not be stated in our problem statement. The other is action or corrections required should not be stated in our problem statement. And we should not assign a blame. We should not. This happens because nurses. This happens because our physicians. No, we don't do that. The other is it should be specific. We have to address only one problem. This is while writing our problem statement. So this is an example of problem statement. From October 2022 to September 2023, the fifth floor medical ward experienced a concerning high rate of hospital-acquired pneumonia. Compared to the facility average, they had 30% more hospital-acquired pneumonia cases. This translates to 9 additional patients developing hospital-acquired pneumonia, each one incurring significant hospital and patient costs and potentially experiencing a lengthened stay of 7 to 9 days. So this statement has timing, almost the problem exists for 1 year. We know where it exists. There is a size 30% more, and there is an impact, increasing average length of stay and increasing hospital and patient cost. So this is an example for problem statement. When we write problem statement for academic purpose, we can narrate more, but we should put in place all the components. After stating our problem statement, we set an aim. As an objective, aim should be smart. So when we setting an aim, we are answering the first question of a model for improvement. That means, what are we trying to accomplish? So aim should be smart. S stands for specific. It should be specific. Only addressing one problem, and it should be measurable. And it should be achievable. And the other is relevant to the patient, relevant to the policies, the guidelines, our vision and mission, and the like, if we are doing in a healthcare facility. The other is it should be time bounded. When we say time bounded, it should have a starting and an ending point. So we can do quality improvement projects for 3 months or for 6 months. In some cases, if we entertain or if we are doing quality improvement projects in mortality in these cases, up to 1 year. Otherwise, 6 months and 9 months is enough to do a quality improvement project. So this is an example of aim statement. By August 30, 2024, the fifth floor medical ward quality improvement team will achieve a 50% relative reduction in the rate of hospital-acquired pneumonia in our ward compared to the historical average from October 23 to September 24. This is a smart aim statement. So after stating our aim statement, we should come up with a plan, a change idea that drives our aim statement. So our aim. So when we developing a change idea, we are answering the second question of model for improvement, which is, what change can we make that will result in an improvement? So how do we get these new ideas? From where we get these new ideas. The first thing is from available standards, protocols, guidelines, and the other is literatures, the current evidence-based practices. And the other is by comparing ourselves to the others, benchmarking. If the others excel this problem, we benchmark their change ideas and we adopt according to our setting. And the other is asking experts in the area to get a new idea. And the other is brainstorming our team. When we brainstorm our team, we get different ideas. And the other is by using change concepts. By mean, change concepts are general ideas that can be used to develop a specific action for improvement. For example, there are known change concepts. If you notice this problem, do this. Like in healthcare setting, there are 72 change idea concepts. For example, if we see a variation in treating a patient at OPD, the patient come up with a same symptom, but different clinicians treat that patients with different. So there is a variation in treating or in diagnosing. So when there is a variation, we standardize. We put a protocol. We standardize that procedure. So that is called a change concept. The other is by creative thinking. Creative thinking means it's thinking outside the box and come up with different ideas. So while developing a change ideas, there are things we should avoid when choosing change ideas. The first one thing is we have to avoid more of the same. By what do we mean by more of the same? More people, more resource, more time. There are more patients in our OPD, so we add more physician, we add more nurse, without reaching into a root cause without doing a root cause analysis and without really getting what is the root cause. So this is reinventing the wheel, and this is traditional way of solving a problem. The other thing we have to avoid while we are generating a change idea is what we call it utopia syndrome. Utopia syndrome means fearing to fail and not taking any action. So some people are like that. They wait to get a perfect solution while the problem still exists. So this utopia syndrome causes action paralysis. So we have to avoid this thing, because in quality improvement there is no failing. We try something and we learn from that, and we improve. So we have to avoid utopia syndrome. The third one goes with the first one. Sometimes we assign a perfect solution to the wrong problem. Adding a human personnel, adding a physician might not be incorrect, but we didn't get what the actual problem is. So we have to avoid these three things while choosing a change idea. So this is a saying: every improvement needs a change. But not every change is an improvement. So while generating a change idea, there are ways or thought patterns. These thought patterns are two. The first one is logical thinking, logical positive and logical negative. This is a backbone in quality improvement to generate a change idea. a logical thinking. And we use lateral thinking as a supplementary, which is a creative thinking. So if we say, you can hear someone say out of the box thinking, out of the box. This is creativity. So this is lateral thinking, and this provocation, six thinking hats, randommetry are the tools we used while thinking laterally. The other is logical thinking. These are the tools: process map, fishbone diagram, Pareto chart, driver diagram, benchmarking. These are the tools while we used a logical thinking, and we see some of them today. The first one is brainstorming. We brainstorm to come up with a change idea, also to identify a root cause, and to come up with a change idea. So brainstorming is a commonly used technique. Even if we used other techniques, brainstorming is there. And brainstorming has two sessions: a quiet session and a silent session, and a session that we speak and we discuss. During a quiet or a silent section, there is no critics or question, because our aim in brainstorming is getting new idea without criticizing and questioning people, and people should tell their ideas without fear. So no critique and no question during the silent session of brainstorming. After getting different ideas, we involve group ideas, and we tend to affinate that things in the same thematic areas. We categorize the ideas in a thematic setting. So this is brainstorming. The other is benchmarking. When we say benchmarking, it is learning from high performers, learning from best practice. So it is we have to understand what they are doing different from us. So we can benchmark hospital from hospital, can benchmark health facility from health facility, but it is not limited to health facility from health facility. We also have to benchmark other organizations, and there are two examples that are recommended healthcare facilities should benchmark. The first one is the aviation industry, the airlines, because of their high safety index, and we do have a problem in ensuring our patient safety, so we have to learn from that. And there are some procedures that are adopted from this aviation industry. The first one is using a checklist. So in aviation industry, checklists used widely, and that ensures the safety. So for example, the surgical safety checklist, we use the surgical safety checklist to ensure our patient safety. And there is also other checklists like safe baby checklist, safer baby checklist. So we learn from the aviation industry about safety, and we adopted that checklist. The other thing we learn from the aviation industry is their audit system. After hearing a plane crash, all the news are about the black box. What the black box tells us what is the procedure from the start to the end. So after finding the black box, they try to audit and they prevent that damage from reoccurring. So we learn about safety and audit from the aviation industry. The other is patient-centered care. It is nice if we benchmark the hospitality industry like the hotels. The other tool we used to identify our patient's problem is process map. Process map is a series of connected action used to achieve an output with a defined start and end time. It's often used to present a patient's care pathway. It helps us to understand the process, to identify opportunities for improvement, and to help us to standardized procedures. And while using process map, we identify values of patients and reduce wastage. So we follow our patients and we map their process. So before following our patients, we have to decide the start and the ending point. The start and the ending point. And while seeing our process map, we look different steps. The first one is steps that definitely add value to the patient, the current concern. The second one is steps that add no value but are unavoidable, like financing, like feeing service. The third one is processes that add no value but are avoidable, like recurring processes are identified. So after doing a process map, we avoid processes that has no value but avoidable, and we rearrange, we design that process again. So the other thing is root cause analysis. Root cause analysis is identifying the underlying reasons, causes of the problem, and change for improvement to be targeted towards the causes. There are two methods most commonly used. The first one is 5 why, and the second one is a fishbone diagram. The 5 why, we say approximately 5 times why. We write the problem. For example, we write there is a delay in a patient being moved from the emergency unit to the ward. So there is a delay. This is a problem. Why this delay happens? We answer this problem. This question. Because there are no more beds in the ward. Why there are no more beds in the ward? We ask question again. Then the answer is because there are still patients waiting to be discharged. Why patients wait to be discharged? Because they are waiting for their medication and discharge documentation. Why they are waiting for their medication and their documentation? Because the orderly has not delivered the prescription to the pharmacy and the patient's file to the central records. Why? We say why. Because they are waiting for the nursing manager to initiate the process. So we act. This is the root cause. We get the root cause. So we act on this in a nursing manager initiating the process. So this is a 5 why. The other is fishbone diagram. Fishbone diagram commonly used in identifying a problem, a root cause analysis in quality improvement, because we have to think systematically. So sometimes, most of the times, problems have many causes. We use fishbone diagram. Fishbone diagram is a visual way to look at a problem and its causes, and a tool that helps to organize contextual knowledge about a problem. It involves brainstorming, and it encourages group participation and utilizes group knowledge. This is a fishbone diagram. We do have different templates. We can get different templates while searching in a Google. So in this part effect, we write a problem, and these option 1, option 2, option 3 are thematic areas like a WHO 6 building blocks. We can say provider, service delivery, infrastructure, leadership, and we thematize these problems and we write problems that cause this effect. So, for example, there is high healthcare associated pneumonia, high healthcare associated pneumonia. So antimicrobial use as a thematic area, staffing education, and the like. And we write causes exhaustively, because our quality improvement relies in identifying the problem. So all the problems should be written in our fishbone diagram. Still, we are talking about identifying the problem because, as Albert Einstein says, most of our time are spent in identifying the problem. So where is the change idea? The change idea comes when we do driver diagram. Unlike the fishbone diagram, in driver diagram, we put aim here as our outcome, and primary driver, a big thematic areas like systems, WHO building blocks, and secondary drivers. After that, change ideas. In driver diagram, we can't use negative words because we are talking about driving our aim. So we can't copy paste our fishbone diagram into our driver's diagram, because our fishbone diagram focuses on the problem, and all the words are negative words: lack, shortage, inappropriate, and the like. So in driver's diagram, we put change idea. So the concept is this change idea drives this secondary driver drives this primary driver, and this primary driver drives our aim and leads towards our improvement. So this is an example: prevent non-ventilatory hospital-acquired pneumonia. So this is our aim. We can put the magnitude here. So there is a primary driver, a secondary driver, and change idea. So we come up with so many change ideas. We should write all the change ideas. But we can't do these all change ideas at once. So what we can do? What we can do? We do a focusing matrix. This is the QA team may come up with several change ideas, but their level of importance, feasibility, implementation may differ, and it may not be possible to test all the change ideas in a short time. Within 3 months, 6 months, we can't. So we focus and prioritize our change ideas like we are prioritizing our problem with different criteria, with feasibility, importance, and achievability. So the team needs to prioritize which change idea to focus on. So after focusing a change idea, we select one change idea at a time. We test that one change idea at a time, and we increase to implement our change ideas after seeing our progress. That is the next session. So we are looking a model for improvement. Yes, right? We are looking a model for improvement. We as I said, model for improvement has three fundamental questions in the PDSA cycle. We answer what are we trying to accomplish while we are setting our aim, and what change can we make that will result an improvement was answered while we are setting our change idea. What is next? The next is how will we know a change is an improvement? That is a measurement part. And the other is testing, doing a PDSA cycle. So we will have a next webinar on measurement and testing, because these concepts are wide and we believe should be understood clearly. So finally, I would like to give some pointers about the quality improvement and research part. In academic setting, currently we are doing quality improvement projects instead of doing research. So what is the difference between the two? The first one is based on their purpose. When we do QI, it is to improve, it is care delivery within a specific setting. And while we do research, interventional research, it is generating new knowledge and new knowledge about interventions. About the intervention, QI is mostly we tend to use the existing practices or small changes. In interventional research, new or experimental interventions. About the risk, quality improvement, minimal or no risk to the patient and to the provider. In interventional research, it might be increased because these are new generated knowledge that are not tested in other places. Regarding review, mostly we don't need a formal IRB review to do a quality improvement project, but while doing research, as we all know, we require IRB approval. About the dissemination, mostly quality improvements shared internally, but currently there are literatures that publish peer-reviewed quality improvement projects like BMG Open Quality, BMG Quality and Safety, and the like. And in interventional research, it is obvious it is published as in a peer-review scientific journals. So these are what I have for today. As a summary, we see the domains of quality improvement and the 5 principles of QI, and we see system thinking is a problem-solving approach, and the components of model for improvement, the 2 components, the 3 fundamental questions and the PDSA cycle. And for root cause analysis, we use 5Y and fishbone analysis. And we have to spend more time in understanding our system and in identifying our problem to come up with a better change ideas. This is the summary and what I have for today. And thank you. And any questions, you are welcome.
Thank you, Dr. Wubet, for such an amazing and interesting session. Would be directly proceeding to the post webinar quiz. Good evening again, everyone. Would be winding up our session now with a question and answer session. You would be first answering questions raised on the chat box and Q&A box, and then you guys will get to have a chance to ask your questions directly to our panelists. This part of the session would be moderated by Dr. Aiden, my co-panelist. Dr. Aiden would be handling it from now on.
Thank you very much, Dr. Robert, for the very insightful presentation. So we're going to be going through questions that you have put forward in the Q&A. In the meantime, please feel free to add more questions or raise your hands up if you have any questions that you'd like to forward to Dr. Wubet till the end of the session. So from the Q&A and the chat box, this was the question that I could find. And the question reads, what are some examples of common and special cause variations? Dr. Wubet.
Okay, thank you. Understanding the common cause and special cause variation is crucial for quality improvement. So it is a very nice question. There is no specific example for this, but when we see our data using a control chart, we might differentiate the special cause and the common cause variations. So when we track, for example, when we track while we are tracking our surgical site infection rates using a control chart, even if it is in our control limit and it is caused by a common cause variation that is inherent to our system, still we might want to decrease our surgical site infection rate. So we might design a quality improvement project. The other thing is when we say special cause variation, when there is some change in OR or a new physician or interns or the like, if there is something in the process of the operation theater, that surgical site infection might be spiked. That's due to the special cause variation. So there is no specific example. This is special cause variation. This is a common cause variation. But our outcome might come from a special cause or a common cause variation. We can say that. Okay. Yes.
Okay, so the second question is something we'll be arranging as well. It's, can you please share quality improvement slides, which we will be doing after the end of this session. The third question is, as the QI knowledge is the integral component of healthcare system top-down, why doesn't our medical curriculum give it much attention?
Okay. I may not be the right person to answer this, but currently it is on the process in different schools to integrate the quality improvement in the curriculum. Like in Yekatit Hospital, residents and interns are getting education, integral education about system thinking and quality improvement. So I think there is a plan at a ministry level to integrate this part in the curriculum, also in another parts of medical schools.
Okay, so the fourth question is, are there times we might fail getting to the root cause when performing RCA? And what methods should we follow to make sure our whys are the correct whys we're asking?
Okay. To do root cause analysis, we use different methods as I mentioned. 5Y and fishbone diagram are used to do root cause analysis. When we use a fishbone diagram, we tend to see our problem from different systems. So mostly we are getting a root cause analysis on point, but sometimes there are bottlenecks. There are bottlenecks that are beyond our scope. Even if we are doing intervention, we can't achieve our aim. Some quality improvement projects or some problems need financial support, or they need structural infrastructure and the like. Also some related to with the policy and our strategies from top from the ministry on and from the government officials. So sometimes we found a bottleneck that needs more attention and more financing. Most of the time, most problems are solved within our capacity. Okay. Next question.
The next question is this model worked, implemented and tried? So since you haven't specified which model you wanted to be elaborated, I'll give you some time to elaborate on that and we'll come back to this question. So the last question was, why do we need quality improvement?
We need quality improvement because in our healthcare system, there are different gaps. As I mentioned, literatures show us there are different no-do gaps. What we are knowing and what we are doing are a lot gaps, and there is a safety issue, and all the quality domains are affected. So we need quality improvement to fill that gap, that quality gap. So when we see patient safety alone, annually 3 million lives are saved by improving patient safety methods. So because of the problems we face day to day in our healthcare system, quality improvement is needed, and there is always a room for improvement. Even if we are doing our best, there is always a gap in our healthcare delivery. That's why we need quality improvement.
Okay, so we got elaboration on the previous question. So the participant wanted to ask if the PDSA model works, has been implemented, or has it been tried?
A PDSA model, yeah, we will see in the next session in detail about PDSA. Yes, a PDSA model is a testing model. We plan our intervention. After planning our intervention, we do that change idea, and after that we study that change idea. What brings that change idea to improve our aim. So this model used in different PDSA cycle, used in different situations, in different problems, not only in healthcare. It is a known tool to come up with a solution for a problem. So we also used there is in other sectors other than the healthcare setting. Even there are different quality improvement projects that use PDSA cycle and come up with improvement. So this model worker to implement our intervention and our change idea and to get a good improvement. Okay. When is the next webinar session? I think after 2 weeks we will have a next webinar section about measurement and testing. Is there other questions?
These are all the questions that were forwarded, but we will give you a couple of minutes so that you can forward any remaining questions you might have. Then after that, we'll go to the quiz questions and we'll go through them with Dr. Wubet, giving you answers.
Please make sure to fill out the quiz as we're about to close the responses and we'll be discussing the answers here. For people who are forwarding your concerns regarding the link not working, the responses are increasing. Please make sure to check your browser and your internet connection. If it's possible, please try to log in using a different email as well. I'll be forwarding the link again. We're about to close the quiz now and would be directly proceeding to doing the quiz together.
Okay. The first question is, which of the following is not included in the domains of healthcare quality? We discussed that all the 7 safety, person-centeredness, equity, effectiveness, and integration are the domains of healthcare quality. So, so the answer is F. The second question is informed consent for hip surgery was obtained and documented for an elderly patient in the recovery room. A nurse discovered the wrong hip had been replaced. A healthcare quality professional should A. Conduct a failure mode and defect analysis. B. Initiate the disciplinary action process. C. Review the practitioner qualification and licensure. D. Perform a root cause analysis. So the answer is D, because after things get wrong, we don't have to assign or attribute that cause to some individual. Rather, we have to do a root cause analysis. The third question is which of the following is not part of Deming's theory of profound knowledge? A. Knowledge of psychology. B. Total quality management. C. Theory of knowledge. D. Knowledge of variation and appreciation of a system. So the answer is B. All the 4 knowledge of psychology, theory of knowledge, knowledge of variation, and appreciation of the system are Deming's theory of profound knowledge. The fourth one is appreciation of the system includes all of the following except understanding process. A. Understanding the process in the system and their impact on the system's aim. B. Considering interrelationship and interactions of each element and system. C. Knowing the roles of each element and process in the system. D. Understand importance of learning from theory of change. So the answer is D, because D is incorrect, because understand importance of learning from theory of knowledge is it is in the theory of knowledge. So the fifth question is a true-false question, which is if someone has subject matter knowledge on specific area, he or she can develop an effective change that can result in an improvement. The answer is false, because to for effective quality improvement, we need both subject matter knowledge and profound knowledge is needed for effective results in improvement. These are the answers. Thank you very much for having me. Thank you.
Thank you very much, Dr. Wubet, for the very informative discussion that we had, and thank you for going through the questions with us. If there are any final questions or any ideas that anybody wants to raise, please forward it. If not, thank you all for joining us today, and thank you for actively participating. Have a good evening, and with this, we'll wind up the session.